All right. Any questions from last time? We were talking about migraine treatment. We talked about triptans. We talked about ergotamines. We talked about all that good stuff. What's medication overuse headache? Yeah, it's basically kind of this hyperalgesia almost, where you have like an increased sensitivity to pain related to overusing a lot of these medications here. And so you're going to find this is oftentimes associated with like overuse of ergotamines and triptans, usually more than, say 15 days per month, right? So more than every other day. And what's the goal? Like how often do we want to be using these? No more than 2 times a week, right, is ideal. Obviously, 0 would be the most ideal out of those cases there, but hopefully not more than 2 times per week. And again, you're going to find that when you try to withdraw these medications, especially if they're taking them chronically, you can see that rebound headache. So again, this is another thing where you want to taper slowly to try to avoid that, because again, if they have a really nasty rebound headache, what are they going to do? They're going to take the medication again, right? So again, that's how they end up kind of staying on those meds for a long period of time. And so again, if they, depending on how severe of the, depending on how much they're actually having to take per day, can dictate whether they can go cold turkey or you need that more long of a taper. Obviously, if they have any withdrawal symptoms, then you want to go ahead and try to, go slower and gently titrate down on those doses there. Okay, just something to keep in mind. So looking at preventative therapy, so what are some things we can do to try to prevent migraines from occurring in the first place? Well, first off, who's a good candidate? Probably going to be people who have those recurrent migraines more than twice per week. Like those are people you definitely want to try to help prevent in the first place. Obviously, they can't take any of the first-line therapies. So, for instance, they can't receive, they have previous history of stroke or something like that, and they can't receive triptans or ergotamines. Like that may be a good candidate for preventative therapy. Pregnant patients, and many different types of patients who may fall into this category here, right? So, what are the first-line therapy? Here is going to be our beta blockers. So, about 80% effective for most patients in helping to reduce the number of migraines they have. So the big caveat here, though, is that a lot of these drugs, what do we say can actually induce migraines? If you look at some of the drugs that can cause migraines, remember that vasodilation is what's causing that pressure. What do you think a beta blocker is going to do to those vessels? They're going to vasodilate, right? So a lot of these medications acutely can actually cause migraines, which seems counterintuitive. However, by starting the low dose and titrating up, just like we give beta blockers to patients with left ventricular dysfunction and CHF, beta blockers can throw them into an exacerbation, but we still give it to them because we know that ultimately, by trying to interrupt that process and try to decrease that myocardial oxygen demand, et cetera, like we know we're going to do benefit to them in the long run. Same thing kind of applies here. By giving something that's going to be vasodilatory at low doses and slowly titrating up to effectiveness, you're going to find you help to prevent a lot of those spasms from happening, right? This is what causes that acute vasodilation from occurring, causing that pressure, causing that migraine. Okay, so these can be very effective, and just be aware that it can actually cause some migraines in some patients who are particularly more sensitive to it. So start low, go slow. Again, propranolol is probably the most common one you think of. If you think back to the kinetics of propranolol, what was kind of something that separated it from some other beta blockers? Yes, non-selective, that's good. What else? What about the kinetics of it, though? Yeah, you don't want to use it in asthma. It's very lipophilic, right? So you think propranolol, you think lipophilic, you think about it getting to the brain. That's why it causes a lot of like, nightmares and hallucinations for older patients. That's why we don't like it for those older patients, but we like propranolol in this case because where do we want it to work? In the brain, right? So it makes sense we'd use something like that. Any of the beta blockers, though, could be potentially effective, though, but we don't normally think about propranolol being the big one, okay? So other anticonvulsants, these are frequently becoming more used, mainly because it doesn't have any direct cardiovascular effects like a beta blocker might. So you're starting to see these used more frequently. So this is where Topamax comes into play. This is where things like valproic acid come into play. And again, we already know a lot about these drugs, so we talked about them in terms for seizures. We talked about them for VPA in terms of using them for bipolar disorder. So we already know a lot about these drugs, which is great. How they're working in the terms of migraines is it makes sense like an antiepileptic by interrupting some of those waves of depression. It makes sense how it doesn't do anything specifically to that vasospasm or that vasodilation, but it helps to prevent that spreading wave of depolarization that leads to that migraine. That's how we think it's working here. And again, the side effects, who might not be a good candidate for valproic acid potentially? Someone who might become pregnant, right? Because you worry about what? Tube defects, right? What else? Who else? Yeah, if they have hepatic issues to begin with, right, that can cause hepatotoxicity. history of pancreatitis, maybe you might want to avoid that. So think about the patients who might be a good candidate for one of these versus another, because you might have a test question will come up, say, hey, this patient is looking to use preventative therapy for migraines. What's a good option for them based off their history? Okay, there's things I want you to kind of think through. It's a higher level question than just which one of these is a preventative medication for. You may still have a question like that. Which one of these would be best suited as preventative? And there might be a triptan on there, it might be an ergot on there, and you're going to say, no, that's not preventative, that's for acute treatment. It's important to keep those two separate in your mind, right? Make sense? Okay. Other things we can try antidepressants. These might be good if you have a patient who has concomitant depression. We can try things like TCAs. We can try things like SSRIs. Those aren't used quite so frequently. I think more often than not, it's something that helps block that norepinephrine that probably has the better effects here by kind of helping to re-regulate that constriction and dilation of those vessels there. And so potentially something like an SNRI could be used as well, like Cymbalta or venlafaxine or something like that would be fine here as well additionally. Okay. Calcium channel blockers could also be good to use here as well. So for instance, verapamil, what type of calcium channel blocker is that? It's a non-DHP, right? So again, think about who might not be a good what type of patient that might not be good for, right? So if they already have a constipation, if they have any CYP3A4 substrate drugs on board, because this will inhibit CYP3A4. Think back to all these things. We already know a lot about these drugs. So again, you need to recall that information because it still could be used on a test, right? Not used against you, so to speak, but you still need to know it so you can use it for your patients, right? And again, similar to beta blockers, this can induce migraines. So start low and go slow with these ones, right? Because again, it's going to cause initially that vasodilation to occur, which can cause that migraine to be induced, right? But it could be good if you have, say, for instance, a patient who could not receive a beta blocker, may not be a good candidate for an anti-epileptic or TCA. This might be a good alternative there. Okay. And also have botulinum toxin. Why do you think that might be useful? Yeah. So Botox basically is what? The paralytic. It's actually the most potent toxin in the entire world. And we inject it in our face so we can look pretty. But we use it for other cases too, right? We use it for things like spasticity, right? We can inject it into muscle groups if we have patients like cerebral palsy, things like that. We also use it for patients with chronic migraines. Oftentimes you find that the muscle, especially in the neck, can pull really, really tight on there. It can induce migraines. So by injecting small amounts into those neck muscles, you can loosen those up. Obviously, you're not doing it enough to where you're completely paralyzing the muscle, but just enough of them to kind of relieve some of that tension is going to help with those preventing further migraines from occurring there.
I used to get Botox in my forehead for my bronchial migraines, and I also had some in my back, and some in my scalp. I didn't get them again because they were really extremely painful. But they tend to help when you get the effect of the migraine, but you don't get the pain.
Okay.
Like you have the extra stuff.
Right, some of the other effects you see of those migraines. Sure.
Have the pain, which is pretty cool, but it's very expensive.
Yes, yeah, Botox is definitely, and it's hard to get insurance companies to pay for it from that standpoint, right? So certainly if you're just doing it for aesthetics, no one's going to cover that, but if you have specific medical indications for it, they oftentimes want you to try other stuff, and once you fail that, the cheaper stuff, then you can try it, because again, this is a procedure, someone actually has to administer this to you, becomes much more expensive from that, and Botox is just expensive in general, because it's...
And you got to make sure the person is put it right, because all the time you'll end up like with megaptosis.
Yep. Yeah. So again, administration, you want to use it from someone who is well versed in the application of it. I always see the signs on the side of the road next to like a Publix or something that says Botox, $10 per unit, and I'm like, I don't want to get Botox from anyone who's advertising on the side of the road, right? Right next to, we can get you divorced for $50 and get your taxes done. And I was like, no thank you. They're probably all the same person, like just in one building. So no, thank you. I'm good. So. But anyway, Botox could be good. Definitely not a first line for preventive therapy, but people, especially if they have just that tension there, like you definitely know that could be sometimes useful for them. Okay. So again, start low, go slow. A lot of times you're going to, oh yes, sir. How does that mostly work? So they do work on the heart, but remember, non-dihydropyridines will still have effects on the blood vessels as well, right? So you could use a DHP or a non-DHP in these cases here. But think about concomitant, disease states. For instance, if they have a history of like angina, maybe a non-DHP might be a good option for them, right? It can help treat the anginal symptoms, prevent those, and prevent the migraines potentially. So sometimes these can pull double duty depending on the patient. Yeah. Anyway, and again, consider what is to be a success. Ideally, you'd like to get down to 0 migraines, but that may not always be possible. So even a 50% reduction might be pretty good for those patients, right? Especially if they're having them multiple times a week there. And then after 6 months of therapy or so, you can kind of consider, okay, do I need to taper? What do I need to do? You kind of reassess at that point for those patients. And can just watch for interfering medications. These can have a lot of drug interactions depending on kind of what else is going on, like verapamil is a CYP3A4 inhibitor, things like that. Okay, and again, this is a good kind of flow sheet, kind of showing you kind of the direction as far as like what medications to try. And again, consider what the comorbid conditions are, because that will then guide you to picking one medication over another. For instance, have comorbid depression or insomnia. Well, a TCA might be really good for that one. Why is a TCA good for insomnia? Sedating, right? Exactly. So that can be helpful with that. You have comorbid seizure disorder, right? Okay, that makes sense. This is using anticonvulsant, or bipolar disorder. Okay, we know anticonvulsants get used for that all the time. So again, I think this flowchart really makes sense based off of what we've already talked about. Look at the comorbid conditions. Look at where you can try to pull double duty. Because again, more meds or less meds is better. Less meds, right? Again, think, hey, that's job security for me, but I like my patients to be on as few meds as possible. They can pull double duty, fantastic. Anyway, migraines in women, we know they typically have a higher prevalence here. Also consider other things that are going on, right? So again, sometimes it's related to menstruation. We know that with hormone levels changing throughout the month, this can have a big effect on either worsening or helping migraines. Some women, when they go on oral contraceptives, this can actually worsen migraines. Sometimes it'll help with the migraines. A lot of it is dependent on the type of estrogen they're being put on. More often than not, it's going to be due with the dose of that or the progestin they're actually being put on. So we'll talk about OB-GYN stuff coming up, I think, probably in the last section of the course, and we'll talk all about oral contraceptives there and some of the issues with those medications. Again, consider if it's pregnancy. Again, what's the best medication for a pregnant patient? No medication, right? But what could you use for a pregnant patient? Tryptophan I'd probably try to avoid if possible. Like, what could we get away with? What's like category A for NSAIDs? Yeah, okay, I guess we haven't really talked too much about it. We'll talk about that a little bit later on. Yeah, sometimes I forget like which class I'm talking to and what I've already covered, what I haven't. Again, we'll cover that pregnancy stuff in OB-GYN just a little bit. I should know that because I just said that.
Really quick.
Yeah, so typically like acetaminophen is very, very safe, right? You consider your categories of medications, like acetaminophen is very, very safe for pregnant patients. You're going to find that oftentimes that's like, it's like using like a BB gun for war, right? Because again, it's just not going to be that effective. NSAIDs are okay in the first and second trimesters. They're category D, which means not recommended in the third trimester, because they can actually close the ductus arteriosus prematurely. There's some other issues, but we'll talk about that a little bit later on.
But if you were to ask what you would give,
I would not ask you anything that I have not particularly covered. So like that's why I don't include a lot of pregnant patient questions on my test typically, because we really haven't talked about pregnancy in depth yet. Once we get to that point, then we'll definitely talk about that, huh? Definitely not ergots, right? And you think about it, like, looking at the fetus, like they need a lot of good blood flow, right? Do you want to give anything particularly vasoconstrictive? Not typically, right? So that's why I like to avoid those medications there. I probably would not want to do a triptan. Yeah, if I can get away with NSAIDs and Tylenol, that's probably going to be better for the most part. But anyway, and then looking at menstrual migraines, again, oftentimes these are going to be predictable, right? They kind of know what time of the month that's going to be coming on, and so they can start to take medications potentially as preventative things beforehand in order to maybe help stave them off, maybe make them a little less severe. So for instance, by using NSAIDs or triptans maybe 2 or 3 days prior to menses, because sometimes with that withdrawal of estrogen, sometimes that can induce migraines, that can sometimes be useful in helping to prevent them from occurring in the first place, right? Again, just like how you can have a patient who has an aura for migraine, they can take drugs beforehand, so that way the migraine hopefully never starts. Same thing kind of happens here, just a little bit longer time frame. And then, as I mentioned, oral contraceptives may promote, may change, may relieve migraines. Some people experience no change whatsoever. It's very dependent on the formulation. I'll show you when we get to that section how many different formulations of oral contraceptives that are out there. The list is like probably from here to the window on 12-point font. Like there's a ton of different ones that are out there. All of it, it's biphasic, triphasic, monophasic. If it has iron, no iron, what progestin it has, there's a lot out there, right? Anyway, so just be aware of that. Other things you can see though is that by changing the components of the pill, whether it's just a mini pill with just progestin, what dose of estrogen they're getting, that can all be playing a big role here. Often vitamin B6 has been shown to be somewhat helpful in helping to relieve these migraines as well. Again, I don't know the mechanism, it just seems to help. So looking at migraines and pregnancy, again, We'll talk about these a little bit more in depth when we get to the OB-GYN section, but obviously treatment of choice is acetaminophen. Probably if you told someone with an active migraine, here's some Tylenol for your migraine, they're going to laugh at you and be like, that's not going to do anything, buddy. So alternatives, you can try using opioids. It's not ideal, but sometimes opioids may be used in pregnant patients. Triptans get into this category, what we call category C. You know what category C means?
Tested in animals, but not tested in human beings.
Yeah, basically it's kind of like the you guys have that drawer in your kitchen where like all the electronics go to when they
The junk drawer.
the junk drawer, right? So the junk drawer of pregnancy categories is C basically, where like we don't really know, right? I would not feel particularly comfortable giving it to my wife if she was pregnant if it's category C. A and B, absolutely very, very safe medications for the most part. Everything else kind of gets put into C. So again, not absolutely contraindicated, but maybe not something I want to jump to. Definitely ergotamine is category X. Do not use ergots for pregnant patients, okay? As I mentioned, NSAIDs become category D, which means not recommended because we know there's fetal harm that can occur, but there may be some clinical situations where it's appropriate. But again, if you can avoid that, it's always going to be better, okay? And again, as far as preventative, we like to focus more on the non-pharmacologic therapies. If you can get away with not having to use, for instance, you can't use valproic acid for these pregnant patients, things like that. If you can focus on the non-pharm stuff, that's going to be more beneficial. So any questions on migraines? As you all have a migraine actively induced right now for your weekend, right? You have a tension headache? Very good. Yeah, there you go. All right, so let's move into the next section. So we're talking about HIV and STDs, another fun topic. So HIV, what is HIV? It's human immunodeficiency virus. Yes, what does that mean? What does it do? So it suppresses your immune system. It does that by depleting your body of what cells? CD4 cells, right? Why are those important? You need them to fight all kinds of things, right? Because again, these are helpful as part of that immune system response. They're helping to signal other cells to come in and help to initiate the inflammatory cascade. But why does HIV get rid of those cells? We're going to find out in just a second here, right? So have you guys talked about HIV in any of your other courses yet? Just yesterday? All right, so you guys are all experts now, right? No? Oh, come on. All right. Anyway, so this is a retrovirus. What does that mean? Does it mean like back in the 70s it was really cool? No. It means it's going to take its DNA or RNA and incorporate it into our DNA so that now we are now factories for this virus to produce new ones, right? And those CD4 cells are the places where that's going to be occurring, right? Now, is HIV 1 and 2? Typically, predominantly in the U.S., you're going to find HIV-1 is the most common thing. If you go to other places like Africa, HIV-2 tends to be more endemic there. Just depends on where you're practicing at. That'll be important only in certain cases because certain medications may work better for 1 versus 2. But again, we're mainly just going to focus on 1 here. Now, again, how is it transmitted? Sexual contact, right? Especially like receptive male sex with men tends to be the most frequently transmitted. What else? What is that? Blood products, yeah, potentially. Remember Ryan White? Ryan White's a program here where we help kids with HIV get their medications. If you're here, Ryan White, that is something that that patient has HIV essentially. That's something you can Google information about that. But he received it from a blood transfusion, so there's a program started in his honor after he passed away many years ago. But what else?
Blood secretion like saliva, tears.
Yeah, potentially. Yeah, what else? What's some of the other big one here huh? Yep, so you can have it with pregnancy. What's the other big one though? You have how about the opioid epidemic? Yeah, IV transmission, right? You're having people sharing needles, right? This is why needle exchange programs are so effective at reducing spread of bloodborne diseases like HIV and hepatitis C, etc. So again, this is another big thing because again, what happened here in Florida once we started cracking down on those pill mills, people couldn't get their OxyContin. What did they switch over to? Switch over to heroin, right? Heroin's frequently given IV, so a lot of people are now using heroin IV. They're sharing needles. Now they're spreading HIV, right? So again, see, this is a big cost of transmission there. Anyway, so what's happening here? And again, what kills these patients? Infection, yes. Infection is going to be ultimately what kills these patients, right? So frequently they start off with HIV once they have the virus. Once they have an AIDS-defining illness, that's when they have AIDS at that point, right? So the acquired immunodeficiency syndrome, right? And then that's where they are more at risk for having these infectious, like the opportunistic infections. That's what's going to kill the patient, right? Whether it be PCP pneumonia, cytomegalovirus, and get certain cancers like Kaposi sarcoma, all kinds of things that can pop up because of this immunosuppression that's happening here, right? And so how are we going to treat that? Highly active antiretroviral therapy. So if you ever hear heart therapy, that's what we're referring to there, right? So tell your patients have a heart. from a pill, and they can hopefully treat their HIV. Now, again, looking at the different ways we can try to manage this, and you're going to find that we're using a kind of multimodal sort of approach with our therapy here and to help manage HIV. We're going to find that we're going to be using drugs with several different mechanisms of action to work together to try to prevent the replication of this virus here, right? So this is a good picture to go back to when you're trying to memorize what different drugs fall into which category. Now, again, before, how do you know if a drug is an antiviral? Just based on the name. Has vir on the end of it. Well, guess what? 90% of these have vir on the end of these names, so these are not going to be as easy to delineate which ones fall into which category. So this is tough from a memorization standpoint of which drugs fall into which category. So just kind of just know that's going to be something you have to spend a little extra time on, okay? Because there are quite a few of them that are out there, right? Anywho, so we're going to be focusing on different steps of the viral life cycle in order to interrupt that, to try to prevent them either from getting in the cell. Once they're in the cell, maybe preventing them from incorporating their DNA into our DNA, or maybe trying to prevent them from actually forming new actual viruses that can then send out to infect another cell. So we'll go over this, but refer back to this picture, and that'll help you out in knowing how these drugs are working. Okay. So anyway, so knowing the life cycle, you have to know it in order to understand how the drugs are working here. Basically, what you're going to find is that the virus is looking for cells that have the CD4 protein on them, right? This glycoprotein that's on the cell surface. Once it detects that that's a CD4 cell, it says, hey, I want to incorporate myself into here. And so it undergoes this process called integration, right? So it's actually going to incorporate its little capsule with our cell, so that way it can make its way in. One of the other things you might actually see is that it has this, they'll have co-receptors that it likes to bind to. And so, for instance, one drug in particular is going to be looking at this CCR5 co-receptor. So keep that in the back of your mind. Once it detects that, it makes it more easy for it to get in the cell when it's these CD4 and that CCR5. Anyway, once it gets in, it uncoats and has a single strand of RNA. The RNA is going to be then has activity of the enzyme called reverse transcriptase. That's then going to form DNA that gets incorporated into our DNA, right? That's called integration, right? They're going to find drugs that try to help prevent that integration from occurring there, okay? Now, again, why is HIV so difficult to treat? It's a really sloppy virus, right? So again, you're going to find that it gets resistant very easily because as it mutates, it doesn't really matter. It's it's such a simple organism that it doesn't really matter if there's mutations that occur there. It can still do its thing. It can still continue going on. And so that's why you're going to find that we have so many different drugs, because you can become resistant. You got to switch over to something else that retains activity. So again, it's very prone to those errors there. But once it gets incorporated, it's going to form that double-stranded DNA. That is a reverse transcriptase. This will be another target for our drugs here. And then that's going to then get integrated into our DNA by this enzyme integrase. Again, another target we're going to be shooting for. Once our cells are now producing that virus, it's going to start to produce all those proteins. Now, normally, what happens to proteins once you form them in the ribosomes? Are they like fully functional once they come out of the ribosome? Nope, you got to start chopping them up and you put them back together. So that enzyme is called protease. There's a protease we're going to be interacting with as well. It's going to be preventing the virus from becoming mature. If you prevent that from becoming mature, it doesn't get sent out to infect another cell. And again, once that happens, it'll then bud out. It's going to go over to another cell, infect that, and then wash, rinse, repeat until you have no more CD4 cells, right? What's like a normal CD4 count? Like above 200, right? So you're going to find 200 is a big cutoff we're going to use for our HIV patients. But you'll find some people, and again, not to make light of the situation, but I had a patient who was in the ICU one time and they had a CD4 count of 2. And someone's like, where are they at? Like in the big toe? Like there's only 2 of them left. Like we know there's not really 2 of them left, but they can get extremely low. They can be 0, right? They can have no more CD4 cells that we can at least measure. So it can become very, very severe, and they are very immunosuppressed. And so anything that comes along, whether it be virus, bacteria, parasite, anything, can ultimately kill the patient, right? So anyway, so we're going to find there's kind of 3 main phases here. There's the acute infection, where you may have an acute sort of reaction to it. Then you'll develop this latent period where a lot of patients are asymptomatic, they don't even know they have it, and they can be spreading it to other people potentially, right? The virus is just sitting there, just replicating, just doing its thing, really being kind of unnoticed at that point. Then we get more into the chronic infection, where they start to maybe someone has, they develop thrush all of a sudden, right? And you're like, well, patients shouldn't have thrush unless they are on certain medications or unless they have immunosuppression. What's going on? And you test them to have HIV, right? These are things you may that may kind of lead them to being diagnosed. And then ultimately, once they have that AIDS-defining illness, that's when we say they have AIDS at that point. So whether it be PCP pneumonia, Kaposi sarcoma, etc. And we'll talk about a few of those. How do we monitor, though, for HIV? What are the 2 things we look at? CD4 count and then viral load. Viral load tells us what? how active the virus is at replicating, right? So again, if you have a very high count, that means the virus is doing just fine, it's just replicating away, doing its thing, right? Very low counts mean you're suppressing it appropriately with your drugs. What does CD4 count tell us? How functional the immune system is, right? How progressive the disease is. And what you'll find is that once you get that HIV level down, that viral load down, you should see recovery in the CD4 count. And that is something we're definitely going to be monitoring for. And we'll talk about ways we can try to prevent some of those opportunistic infections. And we're doing that based off of the CD4 count. Some people end up needing to go on prophylaxis. And then once they have a recovery in their CD4 count, then we actually will take them off of prophylaxis potentially, right? So again, all of it has to do with how well you're suppressing the HIV viral load and then how well recovered that CD4 count is, okay?
What was the normal CD4 count?
Above 200 would be, I don't know what the normal value is off the top of my head, but above 200 is what we consider to be good, right? That's what at least protect. Once you get below that is when you start to worry about some of those opportunistic infections popping up. I shouldn't ask you what a normal value is and not know it myself, but, you know, again.
They kept saying monitor, I just want to know what's the normal range.
Yeah, so and again, whenever you pull a CBC on a patient, you order CD4 count, it'll tell you what the normal range is on there, and again, it'll shift depending on where you're working at, right? Anyway, so again, our treatment goals is to try to decrease morbidity and mortality. Now, again, if you were to contract HIV back in the 80s, what was your chances of survival? Almost zero. It was bad. Yeah, it was a death sentence at the time, right? Have you guys ever seen a movie, The Band Marched On, I think, or The Band Played On? There's a really, again, I don't know. No, I think it was more focused on like the gay scene up in New York at the time. I think because that's where a lot of it was coming. Because remember what was HIV called before it was HIV? It was GRID. It was gay related and something or other, right? So again, because it had that really bad stigma associated with it, a lot of those patients were contracting it. It was really bad. But there's a good movie. I think HBO made it. I think it's like an HBO film. So if you want to check it out, And the Band Played On, it was actually a really good documentary talking about how they kind of first discovered it, a lot of the stigma behind it. And there's some good. There's another one called How to Stop a Plague or something like that. I think it's a Netflix documentary, and it was about the activism that went into actually developing the first medications for this. Right, Zidovudine was one of the first drugs we had for HIV, and that took a lot of pushing to get that done. Because again, when you think about, this is a disease that only affects these people who are doing drugs and having sex and blah, 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 was there a big push, you think, for the government to fund research? There wasn't, right? And that was a tragedy. But nowadays, we do have a lot more good medications for this because we realize that, hey, everyone needs to be treated, right, regardless of what their past is. Anyway, so check out those movies. Again, I hate to give you a movie watching list. Huh? I wouldn't call myself a movie buff, but I like medical movies, I guess. Like, I don't know, there's another one like something the Lord made, which is a good one about like tetralogy of Fallot. Yeah, that one's a really good one. Huh? Yeah, something the Lord made. There's Alan Rickman and Mos Def was in it. That's not medicine based, but again, there's a lot of good medical movies that are out there. Anyway, not to get me off on a tangent, you guys are very good at. I'm better at, but anyway. But nowadays, so we mentioned like back in the 80s. Yes, sir. Go ahead.
But you mentioned the 80s. What about Magic Johnson? Why do you think
he was so as time went on, we had better therapies. I think, if you are, think about, what these patients, what other activities they may be participating in. Like, he was an athlete. He was in good shape. He had access to medical care. He was, multimillionaire, right? So having access to care and being healthy can go a long way for that stuff, right? He had access to the meds. And we'll talk about medication regimens in a little bit, but if you're homeless, doing IV drugs, things like that, like you don't have that access, right? So again, your general health list is gonna be a lot lower. So a lot of that can make a difference. But yeah, you have success cases like that, but that was more of the exception than the rule early on, right? And again, looking at the medication regimens, these patients would be like dozens of pills they're taking a day, multiple times a day. Like, it was very difficult to be compliant with. Whereas nowadays, what's the case? Like, if you have a diagnosis of HIV, it's a chronic disease, right? You can live with that for a very good long time. Oftentimes now we're having to treat the chronic illnesses that they're developing because they're getting older, right? So now we have to worry about things like diabetes and hyperlipidemia and hypertension in these patients. Some of the side effects of the medications are going to be playing a role there, which we'll talk about. But yeah, it's much more of a chronic illness. A lot of patients do very, very well with medications. Some of them are just one-time-a-day drugs. Like, it's awesome. Like, we have really good therapy now for HIV. And so we'll get into that. But the main goal is to try to prevent transmission, if we can, especially for high-risk patients, and then accomplish really like maximal suppression of the viral load and try to recover that CD4 count as best we can. Okay, so we want viral load to be undetectable. We want CD4 to be at least above 200. Right, higher the better. So again, what we're going to focus on, and I've already alluded to this, is you're going to see that drug therapy is going to be the mainstay. I wish there was some non-pharm stuff you could do for this, but there really isn't. It's all drugs. You're going to find you need to at least be on a 3-drug regimen. Okay. We'll talk about what the backbone of the regimen is. We'll talk about what the third agent is going to be to help augment that. Okay. So you have to be on at least 3 drugs, if not more, maybe 4 or 5 drugs potentially. Okay. And again, the question is, when do you start treatment for this? Back in the day, we didn't really have a lot of good evidence because, again, this is a difficult population to do studies in. And again, it's hard when you are dealing with something like this where you know it's a death sentence potentially to say, we're going to give you no drug and we're going to give you drug. You can't do studies like that. So the question was, well, when do you start treatment? And before, we used to wait till the CD4 count got down to a certain level. It used to be 50, and then it was 100, then 200. Nowadays, we realize that's no good. We want to keep the immune system as constituted as possible. So as soon as you get a diagnosis, you start treatment immediately. Okay, so every patient is going to get started on highly active antiretroviral therapy immediately on diagnosis. Okay, and again, what you're going to find is that you need to ensure compliance, because if you are non-compliant with these medications, what do you think is going to happen? Is going to get resistant, right? You're going to find that sloppy mutations that are occurring there will lead to resistance. Just like if you stop taking your antibiotics early, you get resistant bacteria. This goes tenfold for that, right? So you have to make sure you're ensuring compliance, which is tough if you have someone who has poor access to medical care, or someone who doesn't even have a home to go back to. They may not understand that this is something they really have to be compliant with.
How expensive are these drugs?
It ranges, right? Some of the older ones can be relatively cheap. Some of the newer ones are very, very expensive. You can look up some websites online to find some of that. Yeah, very, very expensive. And again, these are going to be lifelong medications they're on. Because again, they're going to have HIV the rest of their life unless we have some new development that occurs. I think there's like a recent case of like a second person being cured with, you said like stem cells or something like that. But who knows how long off until we get a definitive therapy. Yes, sir.
I know once you get infected, there's like the mutations that occur, but once you're infected initially, are the initial viruses pretty similar?
It depends. So again, we're talking about like kind of wild type virus versus more of a curated virus you get from having the selective pressure on it from the viruses there. But it depends. If you have someone who has a very resistant set of HIV and they spread it to someone else, then you may start out with something that's a little bit more resistant to therapy than other people. But in general, and we'll look at empiric therapy, you're going to find that there are general recommendations. These regimens are probably going to be effective for the majority of people on initial diagnosis, right? So we start off with empiric therapy, and then based off the resistance patterns, and we'll talk about those a little bit later, then you tailor your therapy to one versus another drug. Okay. Let's see. So as I mentioned, start early. This will help to reduce transmission. It will help to have fewer AIDS-defining illnesses. So again, you're less likely to get PCP pneumonia, Mycobacterium avium complex, all those other opportunistic infections you're less likely to get if you start early for these patients. Okay. So the main classes of drugs, we'll go into each of these. You're going to have the integrase inhibitors. We'll have the nucleoside, or otherwise known as nucleotide reverse transcriptase inhibitors. These are going to be your NRTIs. This will get confusing because then you have non-nucleoside reverse transcriptase inhibitors. These are the NNRTIs. I'm telling you, this is complicated, right? So again, stick with me. So we have NRTIs, we have NNRTIs, we have integrase inhibitors. Next, we have our protease inhibitors. And again, at least the categories tell you exactly what the drug is doing, right? That's one minor grace. We'll have entry and fusion inhibitors, and then we'll have co-receptor inhibitors. Far and away, the most common ones you're going to run into are these first 4 here, okay? And in fact, more often than not, a lot of the new recommendations are just really recommending regimens with these integrase inhibitors and these NRTIs. But we'll go into these in just a second. Okay. So we're going to find that the nucleoside reverse transcriptase inhibitors, you already kind of know how these work. If you go back and think about your antimetabolites back in our cancer talks, right? Remember how some of those worked as like kind of false nucleotides where they get incorporated into the DNA and then you couldn't elongate that any further, and that triggered off what? Apoptosis eventually, right? You're causing DNA damage to the point where it cannot replicate any further, and so you cause the cell to die off. Same thing's happening here essentially, right? So by inhibiting that elongation of the DNA of the virus, you can't allow it to replicate, right? So again, you're going to be halting its replication in that standpoint. Oftentimes these are based off of either purine or pyrimidine analogs. Again, you don't need to know whether it's a thymidine, a deoxycytidine. You don't need to know specifically what that is. I'm just listing it here just for reference. But I want you to note that the drugs that fall into these categories, if it's an NRTI, if it's an NNRTI, whatever the case may be, you need to be able to recognize that, okay? Because you need to know what drugs go into those regimens and recognize whether it's a valid regimen or not, okay? Anyway, and here I'll put these acronyms that are up here. You don't need to know the acronyms. Just like you don't need to know necessarily the brand names, right? If you long, you can recognize it based on the generic. I will not put the abbreviations on the test. I will have the brand names though. Okay, so just like normal, it'll have the generic and the brand name. I'm not going to put the abbreviation. The reason why I mention this here is because just like you have people who deal with cancer drugs all the time, they talk about ARA-C, they talk about CPM, they talk about VBL. There's a lot of acronyms that go into it. What's the inherent danger of acronyms? You get them confused with something else, and then you can cause medical error, right? So you got to be really careful that you're using your acronyms. And HIV medications are notorious for this. You'll have people who do this for a living, and they'll be, oh yeah, patient was AZT, D4T, and something else, and they're expected to know what that actually means, right? And you'll get there if you work with these patients a lot and you work with these medications. You'll just know it, right? Because that's your shorthand at that point. But just know that it can be really error prone if you're not careful, right? So the stavidine is D4T. That doesn't make any sense, right? Zidovudine is AZT. A lot of it is based off the chemical name itself and not necessarily the generic name. So just be aware if you ever see this out there, that's what they are. They're acronyms for the drugs. Okay. Abacavir is ABC. I mean, that makes some sense a little bit, but a lot of them have no sense whatsoever based off the generic name. Okay. But again, abacavir, didanosine, tenofovir, lamivudine, emtricitabine, stavudine, zidovudine. These are all going to be your NRTIs. They get incorporated into that DNA and prevent further elongation. Okay. So a picture of that would be here where you're having the reverse transcriptase enzyme, right? You have the viral RNA going through, and so that reverse transcriptase will form viral DNA from that RNA. But if I put like a little stopper here on the end of it by having a false nucleotide, like stavudine, like zidovudine, you prevent further elongation, and then cannot get incorporated into our DNA unless you have no more replication of that virus. Make sense?
They're kind of acting like a decoy.
It's a little bit of a decoy, right? It's kind of a bait and switch. Or say, here's this nucleotide, go ahead and use it in your DNA, and then gotcha, right? So you prevent any further elongation. That's kind of how that's working. Very similar to a lot of other antivirals, like acyclovir does the same thing. A lot of our cancer drugs, antimetabolites do the same thing. Same mechanism here. It's just targeted towards the HIV virus. Okay. I guess HIV virus is kind of redundant. The HIV molecule, whatever. So adverse effects you're going to see. So you're going to find that typically this is going to be affecting mitochondrial RNA and DNA synthesis as well. We'd like it to be specifically working just on the virus, but you're going to find it has some bleed over effects, right? It's not 100% selective. And so in particular, like stavudine, didanosine, and zidovudine, you see more side effects with. These are a little bit of the older drugs in this category, but the newer ones tend to have less side effects. And this will be reflected when you look at the guidelines and what the recommended regimens are. A lot of them are going to utilize emtricitabine and tenofovir. You're going to see that in probably like 90% of the first-line recommended regimens because they have a better side effect profile. Okay, but things you can see, things like peripheral neuropathy, things like pancreatitis, things like myopathies, anemia. A lot of these can be hepatotoxic, and so you can see things like a lactic acidosis with fatty liver. Most of the time, these are pretty rare, but just be aware that these interactions can occur here. Okay, lipoatrophy. What do you think that means? Yeah, it's kind of like breaking down the fat. Certain fat tissues become more atrophic, right? We're going to find that lipodystrophy is going to be a big thing you're going to see with another class of drugs. So this one causes lipoatrophy. Just note that. And then one special thing here, you never want to start a patient on abacavir without doing a certain genetic testing on these patients. Basically, you're looking for this mutation called HLA-B5701. Again, probably don't need to know the B5701. Just know that looking for HLA testing for abacavir. If you don't do that and the patient has that mutation, they will have an anaphylactic reaction to it. So again, because we know that risk is so high, if you have to switch a patient, say they were on tenofovir and emtricitabine, and that regimen was not working for them because the virus was resistant, they say, okay, I'm going to switch them to abacavir. You got to do that testing first. If not, they may have an anaphylactic reaction, and then that's kind of on you because you didn't check for it. Okay, so something to think about. All right. So any questions on anything in the first half so far? I know these HIV drugs are going to be a bit of a whirlwind. That's kind of the nature of them, unfortunately.
They're going to be on the exam?
These will be on the exam, yes. In 1 week, yes. I will let you know when the material ends for this exam. It depends on how much I get through today. Okay. Any questions, though, so far? All right. So anyway, moving from the NRTIs, now we have our NRTI. These are non-nucleoside reverse transcriptase inhibitors. Now, again, the mechanism makes sense based off of the name. So before we had the nucleoside reverse transcriptase inhibitors, they did that little gotcha thing where they kind of bound onto the DNA. You couldn't elongate any further, and there you go, right? You're done. these are going to work by actually inhibiting the enzyme itself, reverse transcriptase, but they don't look like a purine or a pyrimidine. They just have a different mechanism where they're going to be actually binding to the reverse transcriptase. So even if you have the viral RNA coming through, it's not going to really want to bind to it. It changes that conformation, doesn't interact with it. And so via a different mechanism, it works synergistically with the NRTIs to prevent reverse transcriptase from working. Okay? So in case you were to have like a regimen, like you ask, okay, what regimens make sense? Having an NRTI plus an NNRTI together, that makes sense because they work synergistically. They're both working on different mechanisms to inhibit replication of that viral DNA. Okay, and we'll talk about the different regimens, what makes sense in just a little bit. So our agents here include delaverdine, efavirenz. We have nevirapine, etravirine, and then ropivirine. And again, for the most part, these are actually not used as often as first-line regimens because there's some issues with resistance. So for instance, if you have a single mutation on the virus, you can end up inducing basically cross-reactivity and cross-resistance to almost every one of these. The one exception would be etravirine. That one does still retain some activity. So these are not recommended first line. These may be used as a backup if the other regimens maybe are not working anymore, right? Pretty well tolerated though, some rash, maybe some elevations in LFTs. Ultimately not going to be probably as effective as some of these other regimens is what we'll see. So decently well tolerated though. And again, think about it. You're not just using one of these drugs for HIV. You're combining a lot of them together. So oftentimes it's hard to determine, well, what's causing the side effects, right? Which one's causing this elevation LFTs? It's hard to tell because you're starting all these drugs together. Ideally, you do one drug at a time, right? So that way you can see how patient responds to it. If that doesn't work, you have another one. Can't do that with HIV. You got to go with the full court press right from the start, right? Anyway, moving on, next we have our protease inhibitors, and these are going to basically be inhibiting the enzyme protease from chopping up that viral DNA into, or the proteins into a more functional sort of virus, right? So again, this is after the DNA has already been incorporated into our DNA. We've already replicated the protein of the virus, but we're preventing it from getting mature, right? So preventing it from getting all chopped up and into the actual functional parts. A lot of drugs in this category, including atazanavir. We have darunavir, we have fosamprenavir, indinavir, lopinavir. Now, lopinavir is very frequently mixed with ritonavir, the combination drug. We'll talk about why that is in a second. We'll have nifenavir, ritonavir by itself, sequinavir, and topranavir. And again, I know what you're thinking. You're like, this is too much. I get it. I did the same thing when I was in school too. I know you have the mind exploding gif. I get it. It's okay, but let's talk about the drugs themselves and some of the effects. Now, protease inhibitors. These were used as a first-line regimens for a good long time. They work very, very well, but the adverse effect profile tends to be a little bit worse with these. So you see a lot of GI distress, and the big thing we are now seeing with these is when you're using them for a long period of time. Before, patients didn't live long enough to really develop a lot of these metabolic conditions, but now these are becoming more important, right? So, for instance, these cause hyperlipidemia. But back in the day, they weren't on them long enough to develop things like atherosclerosis and MI. Now they are, and so you have to consider that, right? So you may need additional treatment for that hyperlipidemia, right? You may need additional treatment for that increased glucose levels, etc. Okay. Also, you can get what they call lipodystrophy, and so this very classic sort of thing you see with protease inhibitors is this buffalo hump that can develop there, and that's with chronic use. You're going to see that redistribution of the fat into it causing that buffalo hump. Why that occurs, I got no clue, right?
Cushing syndrome, though?
Not that I'm aware of. Not aware of it having to do with any kind of endocrine abnormality. I think it's just the drugs themselves. Yeah. So most of those are going to be metabolized in the liver, and so oftentimes what we're going to do is we're going to give them what we call a booster, right? So basically what we can do, instead of having to give a drug, say 3 times a day, 4 times a day, if I boost the levels of the drug such that the levels stay high throughout the entire day, I only have to give it 1 time a day. So how do we boost those levels? Well, we can give an enzyme inhibitor, specifically a CYP3A4 inhibitor. So most of the time we talk about CYP3A4 inhibition as a bad thing, right? We talk about it as a drug interaction to avoid. This is a case where we're using it to our benefit. So 2 drugs that do this, one called ritonavir and then another one called cobikistat. Both of these are either in combination with other drugs as one pill, such as Kaletra, I mentioned lopinavir, ritonavir together, or they may be by themselves. These are potent CYP3A4 inhibitors. They'll boost up levels of these drugs. That way you only have to take it 1 time a day, which is great, right, from a compliance standpoint. And so think about other things, though. Like we mentioned the metabolic complications of protease inhibitors causing hyperlipidemia. Well, what group of drugs frequently is metabolized by CYP3A4? Your statins, right? So again, if you had a patient on simvastatin, you wouldn't want to put them on simvastatin if they're on ritonavir because you know that those levels are going to be boosted up. It's going to cause hepatotoxicity, rhabdomyolysis, So you got to think about what statins are safe to use. Rosuvastatin, fluvastatin are the two common ones, right? Rosuvastatin is more potent though, so you use that very frequently. But atorvastatin, simvastatin, you wouldn't want to use those, right? Think about if you had a patient who had, say, need to be on a calcium channel blocker like verapamil. That's another CYP3A4 inhibitor, right? So you can see how these interactions can start to stack up on one another pretty easily there. So just something to think about, right? So definitely look at these interactions. And again, are you guys going to be the ones prescribing these HIV meds? Probably not. I don't think a lot of you, the majority of you, are not going to go into specifically dealing with HIV patients. However, if you have someone coming in for surgery and they have HIV, if you have someone who is coming to the ER or the acute care clinic to get help and they are on HIV meds, you need to be aware of them, because if you're going to prescribe them something else, so they come in with pneumonia, you want to give them azithromycin, you be careful, because this is another CYP3A4 inhibitor, right? So again, it can throw these things for a loop. You have to be really careful with that. So again, you might see these patients, you have to deal with them, so you want to be aware of what these drugs are going to do, and always, always, always look it up. Look up your interactions. Please, please, please look it up before you kill someone. Okay? I'm just kidding. Don't do that. But please look it up. Okay. Anyway, another group of drugs we have here are the fusion inhibitors. So based off of this, what do you think these do? They prevent the fusion of the virus into our cell, right? So again, they prevent that from actually occurring there. That's different from the integrase inhibitor. Integrase is what actually incorporates the viral DNA into our DNA. This is the fusion of actually getting the virus into the cell. So this is like basically like blocking it from ever getting into the cells in the first place. Okay, we only have one drug for this called Infuvertide or Fusion. Kind of gives away what the drug does in the brain name there. This only works for HIV-1. So this is a case where a drug may not actually be used in other cases where HIV-2 or places where HIV-2 is more endemic. But it works here. And so basically what this is it's a peptide, right? It's a protein. So this actually is going to be one that's injectable only. So to be aware of that. All the other agents we've been talking about have all been oral so far. This is the one injectable product here. And so very frequently you're going to find injection site reactions. Also, if these patients are immunosuppressed and you're injecting yourself, what do you have to worry about? Infection, right? So you got to make sure they're using good technique. They're cleaning off the site appropriately if they're going to be using this. But you know, some other things you can find, like these nodules that are formed, so it's important to rotate the site, especially when they're injecting to the abdomen. Make sure they're kind of rotating around and not using the same site over and over again. Otherwise, you can see some of that scar tissue formation. You can see those nodules start to pop up there. Okay. Next, we have the CCR5 antagonist. There's only one drug in this category called Maraviroc. This is another one that you actually need to do testing on the patient beforehand as well, because you're going to find that initially, you know, our cells may or may not be expressing or will express the CCR5, but the virus may not be looking for it specifically. And so you can actually find that mutations on the virus itself may make it so that before it did require CCR5 to get into the cell, but now they mutated to where they don't need that anymore. So this is actually a testing where we can test and again, this is the only drug that actually works on the human cell itself and not actually on the virus. So that's one thing to note the difference there. But basically, it blocks up that CCR5 receptor site so the virus cannot interact with it. If it can't do that, then it's going to be less likely to get into the cell. Again, this would not be like a first-line drug, but would be maybe something you add on if you have maybe more resistant virus there. Okay. And so this is a big group of drugs I want to focus on here now, because the majority of the initial recommended empiric therapy now focuses on integrase inhibitors now. So and again, this is back when I was in school. So again, I graduated pharmacy school in 2000, was it 10, I think? Even then, I'd never heard of an integrase inhibitor. So again, it's only been 9 years, and now we have all this list of drugs here, and these are the first line recommended drugs here. So again, this stuff changes very, very quick. If you're ever curious about what the new regimen is recommended for HIV, you got to look it up every time because it changes so frequently. What was right 6 months ago? In fact, when I gave, you know, I had a prescription assignment. Did I put one of these on your prescription assignment for this time? No. Sometimes I'll do that, and then I actually had to change it from 1 year to the other because the recommended regimen had already changed. Right. So again, this is something that you have to look up. Anyone know where you find recommended information about HIV? NIH is going to be the place to go to, right? So if you look up AIDSinfo.gov, that is the place to go to, and that will always have the most up-to-date recommended information there. Okay. So anyway, these integrase inhibitors, basically what these are going to do are try to prevent the integration of viral DNA into our DNA, so that way we cannot start to produce, we can't do the work of the virus for it, essentially, right? So a couple of drugs here include raltegravir, dolutegravir, elvitegravir, and then you have bictegravir is this new one, or bitegravir. And again, you'll find like elvitegravir is co-formulated with the cobikistat, a CYP3A4 inhibitor. Again, that's used to boost the levels of the drug, so I give it less frequently. And again, you'll find a lot of these drugs are actually given in combination with some of the other ones. So for instance, we have bictegravir is mixed with emtricitabine and tenofovir. Does anyone remember which category those two fall in? Those are NRTIs. And so you already mix 3 drugs together, and the benefit of that is what? Better compliance. I can now give 1 pill a day in a lot of cases to patients, especially for empiric therapy, and they're compliant. It is so much better. If you there's like old clips out there of patients going through their HIV regimens back in the early 90s. I mean, there's dozens and dozens of pills they're taking. It's awful, awful stuff. Nowadays, 1 pill a day, they're good to go, right? They can go about living their lives, which is great. Okay, so that's why they're going to be working there. Again, very well tolerated too, right? You don't see a lot of the same metabolic complications as you do with something like the protease inhibitors. You get some rash, nausea, headache, but other than that, very well tolerated, right? So good group of drugs here. And these are now going to be one of the recommended first-line therapies here, right? And actually, bictegravir is very, very new. Last year when I taught this, bictegravir wasn't even out, and now it's one of the top recommended regimens for HIV. So again, stuff changes at the speed of light. So, as I mentioned with drug interaction, yes, sir?
So for like, you asked a question about whether that complementary mechanism. I saw that Migraine and the other different like cytidine analogs, so a different days.
Let me get to that. In 1 second. Yeah, we'll talk about mixing the drugs together in just a moment here, right? So anyway, so drug interactions. Like I mentioned, sometimes they're on purpose. So sometimes we're inhibiting 3A4 to try to boost those levels up. But think about, if you have a patient who is immunosuppressed, what sort of maybe respiratory infectious disease might they be at risk for? So PJP certainly. What else? MAC is another one. What else? Tuberculosis. Okay. Well, anyone remember the regimens we use for tuberculosis? We use isoniazid. We use what's the R drug? Rifampin. What does rifampin do? It's a CYP3A4 inducer, right? So think about it. If you have someone who's got TB and now they're on a CYP3A4 inducer, but they're also on an inhibitor, that can mess with the regimen, right? And all of a sudden you're like, man, why the heck? And again, how long do you have to treat TB for? Months and months and months, right? Especially if they're immunocompromised, like you'd be treated for a long time. So then all of a sudden you're like, well, why is the viral load going up? Why is my CD4 going down? What's going on here, right? A lot of it could be related to these drug interactions. You got to be really careful with this stuff when you're looking at these and look for potentially other alternative agents that don't have that same interactions there. Be aware of food-drug interactions. Again, look up, does it need to be eaten with fatty meal? Does it need to be eaten on an empty stomach? Again, I'm not going to quiz you on all of that because honestly, I don't even memorize all of that. You got to look it up though, okay? So please look this stuff up beforehand. So treatment, as I mentioned, this is an ever-evolving process. Here's the website you can go to. Again, you can just Google AIDS info, and you're going to find the website very easily there. And this will tell you all the up-to-date stuff. And so basically what we do know is that the initial regimen should be at least 3 drugs, okay? And again, it's going to sound a little counterintuitive, but one of them needs to be either a protease inhibitor, an NNRTI, or an integrase inhibitor. And then the other 2 drugs need to be NRTIs. And you're like, well, wait a second. You just said you want complementary drugs. Why do you want 2 NRTIs that are doing the same thing? Well, by mixing different purines or pyrimidines there, you're finding you do get some complementary activity there, and they work better together than they do by themselves. Okay. So as an example, initial regimens that are recommended by AIDSinfo.gov is bictegravir, tenofovir, and emtricitabine. Again, they look at several factors. They look at the efficacy of the drug regimen. They look at the safety of it. They also look at, does it come as a combination pill, right? So that way you're only taking one thing one time a day versus having to take several different pills all at once, okay? So this is one of the top recommended regimens here. As alternatives, and you'll find there's certainly caveats as what is listed as an alternative, what situation you may want to use one versus another. But you could also do something like a PI, a protease inhibitor plus 2 NRTIs. So I could do darunavir, but darunavir needs to be boosted by ritonavir, so now this is a 4-drug regimen plus tenofovir and emtricitabine. Most frequently, you're going to find tenofovir and emtricitabine will be the backbone of a lot of these regimens, and then the 3rd drug is kind of up to either what's recommended or based off the patient, what they respond to. And then in NRTIs, you could do like efavirenz plus tenofovir plus emtricitabine. Now, due to resistance issues, you're going to find NRTIs are not as recommended anymore, but there are certain clinical situations where it would be appropriate. But for the most part, most patients, if you just had someone just now diagnosed, an integrase inhibitor plus 2 NRTIs is the go-to regimen. Okay. So adherence, we know, is going to be pretty variable depending on the type of patient we're dealing with, what their social situation is like, what concomitant disease states they may have. If you have someone who has bipolar disorder, as HIV, they may not think they need treatment, right? They may not want to be compliant with that kind of stuff. So consider all these different things. Look at substance abuse issues. If they're still, abusing IV drugs, if they are, alcoholics, that can have an effect on the liver. Like, I have to look at all these different things here, and considering as well, like, patient may be asymptomatic from HIV, and then you give them all these drugs, and all of a sudden they're having all these side effects now. Like, they're going to say, well, this is terrible. I'm not going to stick on this stuff. They don't realize the gravity of the situation. If they let that progress, what could happen, right? So again, all things to consider. Really, this is where a lot of education goes into it. But again, these are usually specialized providers that are going to be providing this info. You can work specifically in an HIV clinic. You know, they have pharmacists there, docs, mid-levels. Everyone's going to be working together to make sure the patient's educated and is going to be adherent to those regimens. So whenever possible, use combination drugs. As I mentioned, if you can get all 3 drugs into one pill, that's going to be fantastic. And that will limit that pill burden we talk about, how many pills they're actually having to take a day. And can help hopefully limit some of the food restrictions as well, depending on the situation. So as I mentioned, some combination pills you may see out there is one called Atripla, which is efavirenz, intracytidine, tenofovir, Genvoya's elvitegravir plus cobicostat. It's a 4-drug regimen altogether. And again, look at these and pick out which ones are which categories, and you'll see they make sense based off the last couple slides, what the recommended regimens are, right? Anyway, so resistance is important. You've got to do testing for these patients. Just like you have to culture out bacteria that you think a patient may be infected with, you have to culture out and figure out what these the virus is going to be resistant to potentially, right? So anyone that gets diagnosed, you're going to start them initially on empiric treatment, but you're going to be doing some testing as well to figure out what they may have resistance to already. There's 2 main types here. There's going to be phenotypic testing and then genotypic testing. What do you think the difference is between these 2? Genotypic is just looking at the genetic structure of the virus itself, right? Phenotypic testing, what do you think is what? Yeah, so phenotypic testing is going to be more akin to what we do as far as actually culturing out a bacteria, exposing it to the drugs, and seeing if it either is resistant, intermediate, or susceptible.
Like little petri dishes with the antibiotics.
Essentially, yeah, like the disc diffusion test, it's more akin to that, where basically you're taking the virus itself, seeing what it responds to, right? So again, these mutations are very complicated. You have no idea how one mutation may affect other ones down the line, and so because of that, genotypic testing can be useful. It's much quicker, it's much cheaper, and it can tell us initially, hey, what is this thing blatantly not going to respond to, right? So it can tell us specifically, is this not going to be a one that responds to NNRTIs? Okay, great, I never need to use one of those drugs for this patient, right? Versus the phenotypic testing will then take all those mutations, all those interactions, and the actual virus, and you test it against those drugs and see how it responds. It takes longer, more expensive, there's some other issues with it, but from that standpoint, cost is going to be a lot higher. So because of that, it's not done as frequently, but you may do it as follow-up, especially if a patient is not responding well to a regimen, right? How could you tell if a patient is not responding? CD4 count's going which direction? Down, viral load is going up, right? Now again, if you see that happening, what's another question you want to ask the patient? Are you taking it, right? How do you take your medication, right? What do you do if you miss a dose? Be a good question. Like, do they just double up that day? Do they just skip it? Those are all things you want to consider, right? So, how do you take your medications? Are you taking your medications? Because again, if you just say, "Hey, are you taking your meds?" What are they going to say? Yeah, of course I am. Right? Again, they're not trying to lie to you out of malicious intent. A lot of times they don't want your disapproval, right? They don't want to get that look, that disappointed mom look from you. They just don't want it, right? Anyway, so just know the difference between those testings there, right? The phenotypic testing is taking the actual virus and exposing it to the drugs to see how they respond. That's where you get that IC50, right? It's the inhibitory concentration. Again, it's not the dose we're going to use. We're going to well above that, right? Because we want to make sure we're inhibiting all that virus. But genotypic testing just looks at the genetic code of the DNA of the virus itself and figures out what it's going to be resistant to. Okay, how about HIV and pregnancy? So generally, you're going to treat these patients very similar as if they were non-pregnant. The benefits here is you want to try to suppress the viral load as much as possible to try to prevent transmission over to the baby, right? And again, by having maximal viral suppression, you limit how much the fetus is exposed to. However, one drug you do want to avoid for these pregnant patients is efavirenz, because this can actually cause neural tube defects. So you can definitely avoid that. Now again, the question is, when do women find out they're pregnant? Right when it happens, they get this like big bright light goes over their head, says you have conceived. No, right? It could be weeks, could be months before you figure it out, right? So because of that, you may not know that exposure has occurred, so it's something to consider, right? If you have a patient who has HIV that wants to become pregnant, maybe switch them off of efavirenz if that was what they were on, right? Try to find a regimen that might be a little bit better suited to that. Things to consider. And then to try to prevent intrapartum transmission, we may give zidovudine as monotherapy. And then after birth, we'll actually give the fetus, well, not the fetus anymore, but the baby, we'll give it zidovudine for 4 to 6 weeks or so to actually try to prevent that virus from actually replicating there and getting a hold, right? Because initially, if you can suppress it before it even really gets a foothold in the patient, then you prevent it from ever. You can basically clear it, and the patient does not have the virus anymore. Okay, and typically avoid breastfeeding. You do worry about transmission there, because again, babies typically don't have a great immune system initially, and then also they have transmission of drugs as well that could occur. So chemo prophylaxis. When I say chemo prophylaxis, what does that mean? Giving you drugs to prevent you from getting an infection in the first place, right? So again, you as healthcare providers, are you at risk for getting HIV? Yeah, you could be, right? Depending on the situation where you're working at, depending on what you're doing, you know. Some of you might be working with a lot of scalpels and sutures and all kinds of stuff, you know, on a routine basis, where you may have a patient who may be exposed, right? I'll never forget my first patient when I was doing an INR clinic, a warfarin clinic, for one of my rotations, my very first rotation, and we had a point of care INR test we would do. So I'd actually have to stick the patient, get their blood, and then put on the test, figure out what the INR was, and we change their dose based off of that. And so at the first patient I ever had, this guy had bilateral below the knee amputations, had Hep C, HIV, had every other disease state known to man coming in, and he had just the most callous fingers I'd ever seen in my entire life. And it's because these are like, this is back in Putnam County, where people are like, they're working out in their yards, and they're just had very callous hands. And so this guy, I had to stick him, and of course no blood's coming out, so I'm just having there trying to milk it. I'm like, this thing's gonna spurt in my eye, I just know it's gonna happen. Of course it didn't happen, but you know, sometimes you think goofy stuff if you don't have perspective. Anyway, but just be aware that you could be exposed, right? So how do we try to prevent that exposure from happening? How do we go about making sure that if you think you may have been exposed, preventing that infection from taking hold? That's kind of what we're focused on here. And so basically, one, you want to know the HIV status of the patient. That's ideal. Is that always going to be possible? Now, you could have sent that patient home 6 hours ago before you realized it may have been an exposure, right? Obviously, you want to go ahead and go with the worst case scenario if you don't know, right? Because again, it could be a lifelong sentence for you, so you don't want to try to prevent that if you can. And so basically, we'll try to start as early as possible, and typically we'll give them a 3-drug regimen of raltegravir, so an integrase inhibitor, intracytidine, and tenofovir for 4 weeks. So that may be the healthcare providers receiving that for 4 weeks to try to prevent that from getting a foothold. In some cases, you may do pre-exposure prophylaxis. So if you know you're going to a high-risk situation, maybe taking it beforehand to try to prevent any transmission, any foothold from taking place there. So for instance, you could take daily just tenofovir and intracytidine, which is a drug combination called Truvada, you could take daily in order to prevent that person from getting the infection. So who might that be? That could be if you have a seroconcordant or serodiscordant couples. So one person has it, the other person doesn't. You want to try to prevent spread of transmission. If you have people who have certain high-risk behaviors, like men who have sex with men, they tend to have a higher transmission rate as well. They want to be protected. IV drug abusers. These are all cases where you may want to give the drug daily to try to suppress that to prevent the infection from taking place. Now, obviously, if you have an IV drug abuser, you'd like to do what with them? Have them stop IV abusing drugs, right? Abusing drugs via IV, but it may not always be the case, right? Anyway, but again, you want to make sure they're seronegative prior to treatment, because if they did already have it and you only gave them that 2-drug regimen, what's going to happen? You can see resistance, and you're not going to suppress it effectively, right? You can still see the virus is going to keep replicating. Okay. So looking at outcomes, we're monitoring our CD4, looking at our HIV RNA load, and ideally, what's the viral load we'd like to get to? Undetectable, right? It may not be specifically 0, but undetectable is our goal here, and we'd like our CD4 count to go back up potentially. Again, if you were giving the regimen for 3 months or so, and you come back and you still see that you have more than 200 copies of the RNA present, that's considered a treatment failure, right? You need to figure out what else is going on. Look at the genotypic testing, potentially phenotypic testing, make sure they're adherent to their meds, and then potentially switch them to a different regimen if you need to, right? Okay, so any questions on that so far? So again, just kind of go back, being able to identify which drugs go into which categories, right? So again, kind of that flashcard, sort of like memorization, that quick association. Because you may have a question on a test, like which one of these is a valid regimen for HIV treatment, right? For heart therapy. You may have 3 NRTIs on there, and you're like, that's not a good regimen, right? You may have 2 protease inhibitors and an NRTI, and that's not a good regimen. And you'll see an integrase inhibitor plus 2 NRTIs. Okay, that's appropriate, right? But being able to recognize those drugs is important. Okay. Anyway, what are some complications of HIV/AIDS? Well, these are our opportunistic infections that we really worry about. And so once you start to get down below 200, you start to worry about things like PCP or PJP pneumonia, as the case may be. PJP is the newer nomenclature there. But basically, and then you start to worry about other things like cryptococcal meningitis. You worry about HSV, cytomegalovirus, especially when they get down really low. Now, I'm not going to have you memorize all of these. I'll talk about a few that are particularly important as far as like drug regimens go that you may see occasionally. But again, the big thing to note here is that once they get down below a certain threshold, you will initiate for some of these what we call primary prophylaxis. Okay, primary prophylaxis means they've never had the disease before, but we're trying to prevent them from having it occur, right? Because again, PJP, we're probably exposed to that all the time, but we have a good competent immune systems. We're not at risk for developing it. These patients, once they get down below a CD4 count of 200, they are at increased risk for that because they are not as immunocompetent as other people would be. Okay. So anyway, once they had that primary prophylaxis, if they get the infection, then you have the actual treatment phase, and then afterwards you put them back on prophylaxis. But at that point, it switches from primary to secondary prophylaxis. So if you ever see that secondary prophylaxis, it just means they've had the disease before, and now we're trying to prevent it from occurring again. Make sense? Okay, and so the guidelines have recommendations on when you can stop primary prophylaxis, how long you need to treat for, how long you need to do secondary prophylaxis for, etc. And so you'll find recommendations there on the NIH website. So anyway, so again, our goal is to try to prevent those opportunistic infections because that's oftentimes what kills these patients. And so you're going to find that chemo prophylaxis is very useful for that. And again, I'm not going to cover everything. I'll talk about just a few of them that I think are more important or things you'll run into more commonly. But certainly check out the guidelines there on aidsinfo.nih.gov. So one thing to consider is that sometimes patients who get diagnosed with HIV, they're actually getting diagnosed with the opportunistic infection. That's what actually brought them in for treatment in the first place, right? So if you have someone comes in for pneumonia and all of a sudden you culture out PJP, you're like, wait a second, this is not normal. Checking for HIV, and all of a sudden, okay, wow, I got both of these together. One thing you can actually find is that you need to combine these drugs together. They need to be on heart therapy, but they also need treatment for that disease state. And so, again, drug interactions are important to consider. That's a lot of drugs to all take at once for a patient. They can see a lot of side effects associated with that. They may not want to be on all those meds. And also, you can have what we call this immune reconstitution syndrome, or this IRIS syndrome. What do you think that means?
Autoimmune response to the infection of your body's.
You're on the right track. So basically, we're making by giving the heart therapy, you're suppressing the virus. The CD4 count is going to start to go up, and that means your inflammatory responses are going to go up as well. So you have this infection that maybe you were somewhat symptomatic from, but all of a sudden your immune system gets more ramped up, and all of a sudden you have a lot more response to that. So the patient seems to get sicker, but it's really just because his inflammatory system is going to be more competent. It's going to be more likely to start to fight off that infection, right? So that's that IRIS associated with ART therapy that you can see there. And so again, it looks like they're getting worse because their fever is going to be worse. Looks like their symptoms are worse, but actually they're getting better. But the patient needs to know that because again, they're going to feel a lot worse. And like, what the heck did you give me? These drugs are terrible. Really, it's actually your immune system's getting better, right? So a few that I want to cover includes pneumocystis jirovecii pneumonia, or PJP pneumonia. It used to be PCP, but now it's PJP. Anyone know what else PCP is an acronym for? Okay, well, what else? You're talking to a toxicologist. What do I think?
Oh, that's
Phencyclidine or angel dust, right? I think about PCP from that standpoint, right? But PJP is now the new nomenclature you see for pneumocystic jirovecii pneumonia. And again, this is something that we are probably exposed to multiple times throughout our lives, but we don't get that infection because we have a competent immune system. And so it actually is a fungus with its protozoal sort of characteristics. However, we've already seen the drug before that we're going to use to treat this, and it's actually going to be sulfamethoxazole trimethoprim. Bactrim, right? We've used Bactrim before. We normally think about it as being an antibiotic, but it does have good activity against PJP. And so oftentimes what we're going to do is once a patient gets down below a CD4 count of 200, we'll start them on primary prophylaxis with Bactrim. And so if you ever see a patient who's on Bactrim, say 3 times a week, maybe they take one pill twice a day on Monday, Wednesday, Friday, or Monday, Tuesday, Wednesday, or Friday, Saturday, Sunday, whatever the case may be. That's a prophylaxis regimen. You'll oftentimes see this as well in cancer patients who we've induced immunosuppression in. We'll see that very frequently as well, because again, they're at risk for the same opportunistic infections as the HIV patient, right? So anyway, so we'll go ahead and do that with primary prophylaxis, especially if they have any history of oropharyngeal candidiasis, because again, that shows that they are immunosuppressed, they're getting those infections. You need to manage that, right? So this would be a case where they'd be on thrice weekly prophylaxis. If they actually get the infection, they need to actually put them on active treatment, and that's oftentimes where we're going to use IV therapy. If you ever see IV Bactrim, you know it's a pretty bad infection, or it's one of these infections, because we try to avoid it if we can, due to some of the administration issues that go along with that. But it's a big thing to consider. Now with thrush, if you see this, Again, be careful, like, because when you see thrush, like, what are some other causes for thrush than just, say, HIV? Yeah, corticosteroid use. Remember inhaled corticosteroids, right? I actually had a case where a student, this was a long time ago, we had a student who was on rotations. This is where you gotta be careful with some of this stuff, where she was in a busy ER. And again, privacy in ER, is that a real thing? Depends on the ER you're working at. When I was doing my fellowship in the ER we were at, it was basically a curtain between all the different bays, essentially, right? How much privacy can you get with just a curtain, right? You can hear everything going on in that place. We had a student though that was like examining the patient, and they saw thrush, right? And said, "Oh, do you have HIV?" The student was just making that association because, again, they saw thrush, they saw HIV, they said, "Oh, do you have that?" Because they didn't know it was in the history. Of course, the patient's like, yeah, like that's not something that they may have necessarily wanted to announce to everyone. Well, guess who's one paper curtain over? Patient's neighbor in the same apartment complex. So they saw each other walking out of the ER together. We both got discharged around the same time. Oh, I didn't know you had HIV. Guess what? Now the whole apartment complex knows about that. You have to be really sensitive with this stuff, right? So again, just as a little FYI, something to think about. Be very sensitive with this information to make sure that you do things with tact, right? That can be sometimes hard as a student because you get excited when you see something, and then you say something that you don't mean to, and then some people overhear that, right? So just something to keep in mind.
Did they get in trouble?
I think the complaint was handled internally at the hospital, and then the student just had a good talking to. We did not expel them by any means or anything like that, but we're just like, hey, you need to be careful with this kind of stuff. And so, it's definitely something you wanted to think about. So privacy is always super important, especially with HIV, something like that. There's still a stigma associated with it, and so if someone knows you have that, they may give you kind of the evil eye, or just, I don't want my kids associating with you. They might, because people are ignorant, right? They just don't know a lot about this stuff like we do. Okay. Anyway, so with thrush, definitely there's going to be a fungal infection on the back of the throat. Typically, with these patients, because they're immunocompromised, there is the possibility they can become much more disseminated, right? Because they're not able to fight off that fungal infection. You become, once it's esophageal, you're able to have hematogenous spread. They can develop this candidal infection. And once that happens, once it turns into a pneumonia, it can be very difficult to treat, right? And so this is where you really want to be kind of proactive with this one. Now, we don't do primary prophylaxis for things like thrush, but certainly we're going to treat that. And so how do we manage thrush? Anyone know? Nystatin's a really good one. Why do you like nystatin? Is it working locally? Does it get absorbed at all? Nope, because they can swish and spit or swish and swallow, whatever the case may be. It works great from that standpoint, which is nice because if they're on heart therapy, they're going to be on a bunch of drugs that can interact, right? And so things like fluconazole have 3A4 inhibiting activity, right? A lot of other antivirals or antifungal drugs like ketoconazole, fluconazole. Do you remember how they work specifically to inhibit fungus? They inhibit the fungal CYP3A4, right? So they actually inhibit the CYP enzymes that the fungus needs to build their walls. That's why it has that cross-reactivity with our CYP enzymes, right? So again, it kind of makes sense if you go back to all those mechanisms there. But we like nystatin because it's not absorbed. You limit the systemic side effects, etc. No drug interactions there, okay? But again, if you see it, make sure the patient's aware of that. Hey, if you see those little white plaques at the back of your mouth, like you need to get that treated, right? You need to let us know about it. Okay, other ones you can see, things like cryptococcal meningitis, toxoplasmosis, herpes zoster, cytomegalovirus. I'm not going to get in depth onto these, but again, look this stuff up. Just know these patients are going to be at bigger risk, especially as the CD4 count gets lower and lower. Again, you have a patient who's got, as I mentioned, that ICU patient had a CD4 count of 2. Who knows what the heck they're growing at that point, right? So you have to do all kinds of testing. You're testing for bacteria, sure. You're testing for viruses if you can. You have to do things like acid-fast testing for things like tuberculosis or Mycobacterium avium complex. You're doing fungal cultures. Those two, they take a long time to come back. So you got to have a patient you're treating empirically with all kinds of drugs. You have no idea if it's going to be effective or not because you don't know what they're growing yet, right? And again, when you always want to get cultures, you're handling these patients before antibiotics, if you can, right? So always try to get it beforehand if possible. Okay. Other complications you're going to find, these patients are living a lot longer, so now we have a lot more chronic conditions they need to deal with, right? Hypertension, cardiac disease, stroke, all that kind of good stuff, diabetes, right? So be aware of that, and then you need to monitor these patients, you need to be looking for these things, and look for the drug interactions, right, if you're going to have to manage these other comorbid conditions. Also, you can see things like HIV-associated nephropathy, so you've got to look for renal function to make sure that's staying appropriate. Otherwise, you got to redose your drugs, so something to consider there. And then, of course, there's things like cancers that can come along with this, lymphomas, Kaposi sarcoma, etc. And again, just always look for those drug interactions. Again, if you take anything away from my class, you go out into rotations, what is it? Look it up. The worst thing you do is be confident in what you know, be overconfident, and then say, oh yeah, I got that. and then you don't got it, and it's not good, right? So always look stuff up. Okay, let's talk about STIs. Again, not the vehicular kind. I tell you,
That's pretty funny.
right? So did I tell you my STI story? I announced that I have an STI. I was this is back in the day. I was living in an old neighborhood, and I was going for a run, which is again was a pretty rare occurrence. But I was going for a run, and had music playing in my headphones. I'm running along. I see another guy who's had an STI in his garage. And I say, "Hey, it's a really nice car," and he yells back to me, "Oh, thanks." And I yell back to him, "I have an STI." Right.
Like, good for you.
You're right. He's like, awesome. Good. I'm gonna go back inside now, right? It's a random person yelling at me. Also, my car has a button for the center differential. How do you think it gets abbreviated? C diff. Yeah, it's my wife when she first got in the car. She's like, your car already has C diff. You've had it for like 5 minutes. I'm like, Anyway. That was good to joke at yourself a little bit. Anyways, let's cover a few sexually transmitted infections that occur here commonly. Again, you always think about like again, you guys just came back from spring break. We always think about the teenagers coming back from spring break or college students, coming back with something they didn't intend to, right? What do they say? Leave only footprints, take only memories. Sometimes they come back with a little extra, right? Anyway, so I'm only gonna. Have you covered these STDs before?
Yeah.
A little bit. Okay, I'm going to talk mainly just focus on the drug treatment here. I'm not going to get the diagnosis and all that kind of stuff, but really just want to focus on the drug treatment. The problem with a lot of these, though, is what? Patients may be asymptomatic, right? Patients may not necessarily be all that compliant, especially if they're engaging in high-risk behaviors and may not necessarily want to be compliant with a lot of drug regimens. So what do you think we're going to do to try to ensure compliance? Yeah, so we're going to make sure we have ensured compliance where they either need just one dose or give them something parenterally, so that way they have forced compliance, right? Because again, we want something that's going to be able to eradicate that infection, because the worry is they're going to spread it to someone else, right? They're going to share the love, so to speak. So we don't want that to happen. And so again, what you're also going to find is that patients with some of these immunocompromised conditions like HIV, they're also more likely to spread those as well, right? That helps to enhance the transmission of a lot of these sexually transmitted diseases. So gonorrhea specifically, we're going to find that the treatment for this is going to be IM Rocephin, right? So if you ever need a shot of Rocephin, this is typically what you're treating here. This is gonorrhea. Now again, ceftriaxone is what kind of antibiotic? Good. Third generation cephalosporin. Notice here we're not given a really huge dose. We don't really need that big of a dose. Normally think like a gram of Rocephin as a typical treatment for like pneumonia or any disease state. But just 250 IM, and that's a one and done kind of thing, which is great. That's what we want, is one and done sort of treatments here. You give it to them in the ER, urgent care clinic, wherever you happen to be, and they're good. Now the thing you have to consider though with gonorrhea is that what else usually comes along with gonorrhea? Chlamydia is its best friend, right? So they often come along as a co-infection, and so you need to make sure you're treating that as well. So in that case, what do we give for that? The Z-Pack, right? We're not giving a Z-Pack necessarily, but we're giving azithromycin. So we're going to give a one-time dose, a big 1 gram dose of azithromycin. And normally when you think about a Z-Pack, anyone know the dosing of that? 500 on day 1 and then 250 on days 2 through 5, right? It's a good thing to have in the back of your head. That way, it's a good common one you want to know. But because we know azithromycin has a good long half-life, we can just give it one really big dose all at once, and that oftentimes is going to be able to treat that chlamydial co-infection there. So that's usually pretty good. If you had to use an alternative, you could use something like doxycycline twice a day for 7 days, but what do you think that means for compliance? Not as likely for it to occur, right? You got to go to the pharmacy, you got to go pick it up. They may not go to the pharmacy, may not pick it up. So these are things you want to be thinking about. Okay. Now, again, if they have a cephalosporin allergy, there's not a lot of good alternatives. But of course, with any allergy, you want to ask a question. What kind of allergy was it? If you don't suspect that it's actually true, they say, oh, I got penicillin as a kid. My mom said I was allergic. That sounds a little iffy, right? So again, you can try giving them a dose there in the ER. Again, it's just a one-time dose, see how they respond to it. Again, if they're going to anaphylax, the ER is probably the best place for them to be anyway. So at least you can know, yeah, we have a definitive allergy here. But for the most part, most patients are not going to have a cross-reactivity, even if they say they're penicillin allergic, even if it's a true IgE-mediated reaction, less than 1%, especially with the third generation cephalosporin. So you should be good from that standpoint. Anyway, if you were to have an yes, sir. Yeah, the drug's still there. Yeah. So yeah.
Insurance pay for it because
they may not pay for the ICU stay when you have to, admit them for observation after they anaphylax, but they'll probably pay for the Rocephin. I have no idea. Yeah, it's a good question for billing people. Yeah, there's probably some labyrinthine process for all of that to figure it out. But again, you want your documentation to be good, right? You say, hey, like, I really think this is not a legitimate allergy based off X, Y, and Z, so I feel comfortable giving this, right? Because you want to be able to back yourself up. You want to just say, well, they said they have a cephalosporin allergy, so I went ahead and did it anyway. That's not good. But you have a lot of patients who will have cephalosporin allergies on their list, and I look through their history, and they've gotten Rocephin like 7 or 8 times. I'm like, okay, well, I know they tolerate it well, so we can go ahead and give it anyway, right? There's something to think about. And if you had an infant that was born to a mother who had gonorrhea, we'd use erythromycin ointment typically. Typically, just apply it to the eyes because we're all worried about that being kind of the most likely mucous membrane to kind of be affected, or very kind of high risk membrane to be affected. So we'd go ahead and apply that there to prevent any infection from taking place. As you mentioned with chlamydia, again, this is the second most frequently reported STD there behind HPV. And so again, it's probably twice this because there's a lot of underreporting goes on for this, and a lot of patients tend to be asymptomatic, more so than they would be for gonorrhea in these cases there. Again, azithromycin 1 gram once PO is a great option for that. If you need doxycycline as an alternative, you could. Maybe a fluoroquinolone, but we like to avoid those if you can because you have to treat them for longer, right? So you just want one and done sort of treatments there. And again, we use oral erythromycin potentially for these kids that may develop infection as well.
Why do you not treat gonorrhea?
I probably would end up doing both at the same time. Yeah. So again, just with both of them there, you're probably just going to treat for both anyway. Yeah, pretty common occurrence there. And a lot of times when you look up, like you got like order sets or something like that built into your EMR, like you'll have like an STD order set. You'll just click the button, it'll automatically order both of them together anyway. Just that way you don't even have to think about it. Yep. For syphilis, this is a spirochete, treponema pallidum. Sounds kind of like a Harry Potter spell, a little bit. But again, this is something you want to be careful because if it does progress, it can get much more systemic and cause some pretty severe things like neurosyphilis, things like that. So it can be fatal there. The treatment for this is just plain old, straight up penicillin G, right? Now, we don't see penicillin G getting used a lot for many things. This is a good case where this is going to be recommended here because even though it's been around forever, it doesn't really show a lot of resistance with syphilis, which is great. And oftentimes, if we need to treat it on an outpatient basis, we give them a single dose of IM benzathine penicillin G. Remember bicillin we talked about, the one you only give IM because it comes that nice oily base. Looks like it's almost like milk you're administering. That is good. If you have more invasive disease, that's where you need to switch over to using IV penicillin G, right? And that's where oftentimes if you ever see a patient on continuous infusion penicillin G, it's either for something like this or for like endocarditis. Those are probably the two main cases we're going to see that. A lot of units. I don't know the dosing off the top of my head. A lot of units to treat that because again, like neurosyphilis can be like really, really bad if it develops that far. But again, benzathine penicillin G, that's usually like 1.2 million. You're going to administer for adult patients. Yeah, typically. Anyway, as I mentioned, for those more severe cases, the continuous is the most common one. And that makes sense why we use continuous penicillin G, because if you remember, is it time dependent or concentration dependent? It's time dependent, remember? It needs to be above that MIC for as long as possible. Remember, concentration dependent, we give a big dose all at once, and then we get that post-antibiotic effect, right? All this stuff keeps coming back no matter what. Oh, you can't forget anything, right? Anyway, for herpes, this is going to be, we can either see HSV1 or 2. Again, does HSV1 only show up in the oropharynx? No, it can be either place. Both of them can show up anywhere. Again, how are we going to treat this? Anyone know? Antivirals like acyclovir, valacyclovir are going to be your go-to, right? You may need for more, like if you have like a HSV encephalitis or something, you may need some more hardcore like IV antivirals like foscarnet or something like that. But usually acyclovir and valacyclovir are going to be the most common ones you're going to see here. The big problem with this one is that you have patients who have recurrent infections, these exacerbations, but are they still able to spread the virus even if they don't have active lesions? Yeah, absolutely they can, right? So this is one of those things where we have to worry about them spreading it to other people, even if they don't have an active flare-up. Some of you might not be old enough to remember this, but I remember back in the day when I was like on summer break from school, and you'd always see these like drug commercials that would come on all the time. I remember Valtrex first came out, and they like show these people like kayaking on these like big rivers and doing whatever, just having a great time. Like, just remember, even if you don't have active, sores or lesions or anything, you can still spread it to your partner. Blah blah blah. I always remember that, right? So I always think about sometimes drug commercials can teach you some decent stuff, but Again, the goal of treatment for these are typically we have to shorten the course of the exacerbations if we can, try to help them clear that a little bit faster, and then hopefully decrease that disease transmission. As far as the pain and discomfort go, usually analgesics, antipyretics are totally fine. Tylenol, NSAIDs, things like that are fine. You just want to be careful, especially when they're like itchy or they're patients like scratching them, things like that. You can see a bacterial infection secondary to that, so you want to keep them nice and clean if you can. As far as recommendations go, typically we'll use something like acyclovir or valacyclovir. Again, a lot of it depends on cost and what the patient can cover from an insurance standpoint, and that helps to limit the duration there. Obviously, as with any viral illness, when do you want to start treatment? Early as possible, right? So the sooner you start treatment, the sooner it's going to be effective, the better off you're going to be from that standpoint, right? And again, for more, if you have immunocompromised patients or more disseminated disease, IV therapy is going to be recommended for those patients there. However, you do see a lot more toxicities from that, like bone marrow suppression, renal toxicity, etc. Okay. Now, some patients, for recurrent infections, you may either be on episodic therapy, where they'll be on it just when they actually have exacerbations. Some people do better with chronic suppression therapy. That ultimately helps to limit the number of recurrences they have if they're taking it every single day. Of course, think about the side effects they may be having. Maybe episodic therapy might be better for those patients. So just something to kind of think about. Okay, I'm sorry, I'm just going to cover this real quick. I'm going to stop it before the hepatitis section. That'll be I'll let you know when the end is. So just give me a few extra minutes if you don't mind. For trichomoniasis, Flagyl is going to be your drug of choice here, right? What do you remember about Flagyl? Not to recommend.
Don't drink alcohol.
Don't drink alcohol with it, right? Why? That sulfurane reaction, right? You get that flushing reaction. You want to avoid that, right? Anyway, so tinidazole is also an alternative, kind of like a cousin to metronidazole that you can use to end up managing this. Again, this is another case where you want to give a single dose to be one and done with it, right? So again, 2 grams is a one-time dose of either one. This is going to be fine there. And actually, this is something where there's new legislation out there now, at least in Florida, where as a pharmacist, I can actually fill a prescription for metronidazole for a patient's partner without actually ever having seen them. You can write a prescription without having ever seen that patient's partner. Why would you do that? To prevent them from spreading it back and forth to each other, right? Or potentially, if the patient is asymptomatic, they may not even know they have it. Right, so it's something you want to make sure that you want to consider there is treating the patient's partner as well.
Isn't that scary though, in case like you don't know like their allergies and stuff?
They have determined that the risks are outweighed by the benefits, right? So again, the ultimate societal benefits of treating that patient outweighs the relatively minor risk that they'd have a bad reaction to the medication. Yeah. Mm-hmm. Okay. So, any questions on that so far? Yes, ma'am. Actually, just review the rest of the slides on your own. Should be good. Just kidding. Don't do that.
For like the antibiotics and things like that, would it be a good idea, go back and like
that would be good to know. I'm not going to ask you specifically. Rocephin is what type of antibiotic? I'm not going to ask you that question, right? But I may ask you, hey, a patient, has an allergy to a true documented type 1 allergy to Rocephin. Like, what's a good alternative to that for treatment of gonorrhea, right? That kind of stuff you want to know. Just general information about those drugs you still want to at least be aware of, right? Disulfiram reactions with Flagyl was a good recommendation for education for a patient receiving Flagyl for trich. Avoid alcohol, right? Those kind of things you still want to know. Exactly. Yeah. Exactly. Mm-hmm. Just like with anticoagulants and stuff, we need to know that for I think there's like a part where it made it switched over. I'm trying to think, like the ortho stuff. I think we talked about anticoagulants briefly, maybe. I can't remember that. Turn up on the test or not. Anyway, all right. So that's it for this test. For next week, if you have questions, please feel free to send them to me early. Please early rather than later. So, because again, 5 minutes of me looking at something can save you an hour or more of studying later on. Keep in mind. Let me look at the board real quick to see.